Good morning, everyone, and welcome to the Department of Medicine Grand Rounds, which today we are honored by the Gaspar Carrasquer family. This is the 2025 Gaspar Carrasquer Lecture, and it is actually presented by our Division of Nephrology and Hypertension. We have a wonderful speaker, Dr. Michael Kraus, who comes to us from University of Indiana, and he'll be talking about what doctors should know about organ procurement opening the black box. To do the proper introduction, we have our own Dr. Jacobs. Dr. Alfred Jacobs is a professor in the Department of Medicine. He's actually been here a really long time. He's a Louisville Cardinal going back to his med school days and graduating in 1982. So please come on up, Dr. Jacobs, and do our wonderful introduction. Thank you.
All right, thank you. I have the double pleasure to say a few words about Gaspar. Gaspar was a long-standing person in the Division of Nephrology. He came to the United States from Spain in '53. Did his residency up in New York and here at General Hospital. And for those people who haven't been around as long as I have, that's that yellow building across the street from the new Louisville Commons thing that they're putting in there. He was a research oriented gentleman, and he did the hard stuff. He worked out his area was electrophysiology of kidney tubules, working out the channels and stuff. And he had his own lab up there with the micropuncture stuff and all the fancy equipment and stuff to be able to do that, especially for the time. He was an educator. He liked to talk, liked to educate. As when I was a second year medical resident or medical student, I took his renal physiology class, and I think that kind of bent me in this kind of direction. So let's see, he had a number of papers in a very basic science field, and he was a constant presence in our division, and we think very fondly of him. Okay, so that's can I move on to stage 2?
Sure.
The lecturer we have today is Mike Kraus. Mike did his fellowship in nephrology in Iowa, and excuse me, he's a Hoosier native to begin with, but he did his nephrology fellowship in Iowa and came back and has worked for a long time for the University of Indiana. He's played a major role in that. He was a clinical chief for years and years and years. I'm sure he's done tons of stuff. He's got 60 plus articles he's published and stuff. A big portion of his stuff was kind of renal replacement therapy. So he's was involved in ICU dialysis and stuff like that. He developed a huge home program with both a very large home hemodialysis program and a peritoneal dialysis program. He was called upon to consult and work for some of the big dialysis companies and dialysis machine manufacturers. And now he's kind of moved on to a little bit of a different form of renal replacement therapy that he's going to talk about for us. He's a great guy to work with. Anybody who rides bikes is a good guy for one thing. So Mike, thank you very much.
Thanks. I'm glad this first slide's up because I remember when I did come a little over a decade ago to talk to the division. I believe your father was there. And I did home dialysis, and he had great questions. He paid very close attention. It was impressive. So I've been in nephrology, and I was the clinical chief for a long time, ran our home dialysis, and I was chief medical officer of our dialysis services, did a lot of academics and a lot of administrative stuff at Indiana University. And then about 2017, the world changed, and there was concern about supporting home dialysis from a government's point of view. And so at that point, I went to industry to see if I could help and make things a little bit better in industry so that we could continue home dialysis, because I was exceedingly passionate about that. And then early this year, I completely changed. I figured it was good. It was first starting in the ICU and going a lot to home therapies, and then moving to the best renal replacement therapy, that is transplantation. I moved to the procurement side. And what I learned there is I knew nothing, right? 30 years in nephrology, academics, internal medicine, no knowledge of procurement, right? And as we think about that, we probably said the same thing today. Even my good transplant surgeon is on the recovery side, but a little bit different than how the whole procurement world works. And I think that's important, especially in today's world. Oh, do I have? Yeah, I have a few conflicts of interest for things that I've done. They're fairly straightforward. But the reason I wanted to talk about it, because in today's world, this is important. I don't know if you saw at HHS just had a meeting in the middle of last month where they closed the University of Miami procurement agency. And Robert Kennedy was kind enough to say very bad things about procurement in general. The press not understanding the system, still the same. We'll talk about a little about that. But I think it's really important that you as physicians understand what procurement and donation look like, because words matter. When somebody says words like harvest, you don't harvest organs, right? You recover them for a gift for a transplantation. And when they refer to procurement people as vultures, because we're in the ICU, those are just bad words, bad perceptions to give. And you'd be surprised in the ICU what an ICU nurse or a physician can say two words that turns down donation for somebody that hasn't signed up, or turns the family against donation for somebody who has signed up. So understanding this process, I think, is exquisitely important for people, particularly in internal medicine, certainly our subspecialties, and anybody involved in transplantation. And teaching your families, your friends, your ICU nurses about it, I think, is important. So at the end of the day, all I really want you to do is be able to talk to family and friends. Put procurement in the right spotlight, and we'll understand why. It really is so much more than what we perceive. But for any organ disease, and I put kidneys up there for obvious reasons, there's process, right? You get a kidney disease. There's diagnosis, there's prevention and progression, working on diet, reducing protein intake, getting rid of meats if we can in the nephrology world, controlling blood pressure, absolutely critical, treating the proper disease with the proper medications, which are improving every day. And if those fail, then you've got to begin to think about the process of renal replacement therapy. As it goes on, you've got to understand what's going to be the biggest morbidity and mortality for your patient. In those cases, it's cardiac risk in nephrology, it's volume control, and it's making sure your patients understand their journey better so they can make proper decisions at the right time. And that's where I've lived my world. And then moving, of course, to replacement end-stage renal disease, that's home dialysis first. But transplantation is the gold standard. And you can change this from kidney care to heart care, liver care, pulmonary care. It's the same slide, except in all of those organ progressions diseases, we don't have replacement therapy. So if we don't have transplantation in those therapies, it's death. So you're at those critical points, that juncture, that's the options. You either get transplanted or you progress and die. So it's critically important to think about where transplantation fits in there. There's living donation, kidneys, liver, and bone marrow, can't do a living heart donation. But we're going to focus on deceased donors today. And there's reasons for that. But you can see, first of all, number of organ systems we can improve patients' life or keep them alive. And it's absolutely critical. And I didn't put tissue on here, but tissue is the other half of what I do. And one tissue donor can impact hundreds of people's lives. So it's very critical that we understand those things, we understand the process. And I think we all get it from our point of view. You got the sick patient, they get a life-saving transplant. That's what we perceive, right? And we live in our worlds either on this end or this end, when we forget what's in the middle. And that's the mysterious black box. Where do our organs come from? And at the end, we can talk a little bit about xenotransplantation. It's not my expertise, but we can if somebody has questions. But in today's world, these are donations, right? Either living or deceased donors. And as we look at it, the bottom line is deceased donors. Living transplantation hasn't increased, as you can see from this slide, it's the light blue, for decades. We perceived when we went to laparoscopic kidney donation, and now even laparoscopic partial liver donations, that would increase living donations. It's better for the donor. It has not increased donation. What drives transplantation in the United States and frankly the world today is deceased donor donation. So we have to understand that. And I think we have to understand what it entails to get there. What is in that black box? And that's, again, why we're doing what we're doing. Because today's world is not pretty, right? The press, lay press, looks for stories because that sells newspapers, that sells books. The government becomes interested in those. And I don't want to dwell on any particular story, right? Not important. The point is they're out there. Because a story about something that happened in Missouri affects the rest of the nation. It doesn't matter where the story occurs, or even frankly what the facts are, because usually we don't know that. You guys all live in a world of disinformation. And we're comfortable for that. And organ procurement's there. But we're now in a world where the government, Robert Kennedy here, puts out a memo that says they found systemic disregard for the sanctity of life in organ transplant system. What does that do? Those words matter. They impact everybody. They impact today's donation. They impact tomorrow's donation. And are there errors? I am certain, and I'm young in the procurement world, so I'm not an expert of how everybody runs, but everything is a Gaussian curve, right? And I'm certain there are very good OPOs and then some that aren't as good. Systemic disregard for life and sanctity of life is a very harsh statement that, frankly, I don't believe is true. But it's one of the few places in the world where the Republicans and Democrats get on the same side of the page and say, OPOs are bad. So I've gone from 8 years with the Dialysis Corporation, who was an evil empire, because they all are, right? Because that's how we perceive these things. Now I'm in the OPO, which is another evil empire. So I'm very comfortable with people throwing darts at me on a regular day. So what we do know, the transplants work. Over 48,000 transplants were done in 2024. And we also know that people die every day on the waiting list. We know there's roughly 100,000 people on the waiting list. That hasn't changed. It's been relatively stable. But despite the fact that we're saving lives, that we're growing transplantation, the negative impact is there, as we said. And you get stories for all sorts of reasons. There's a Kentucky story recently. Again, details of those sort of things aren't important for today's talk. They're out there, though, but they poison the entire well, right? And then we get, again, the HHS saying the entire system must be fixed and saying that we're, procuring organs from living patients. And what that boils down to is a misunderstanding of the entire process. And frankly, minimizing what a good OPO should bring to you and your patients. So is there an impact? Yes. People are not signing up to be organ donors. It's going down consistently for the last 2 years. This is national data. Actually, this started a little bit earlier. And even Indiana, it impacts us, right? We've done a very good job. We market aggressively. We do things. And now for the last 2 years, there's been a decline in people signing up to be donors. And frankly, an increase in those that say no. So there's a perception out there that is negative that will impact you, your patients, and the future of transplantation if we don't understand what's going on, if we don't pay attention to what's going on, and frankly, if we don't do a better job. I always tell wherever I work, I don't care how good we are, we need to be better. And same thing is true in procurement. And I think Indiana's a really good program, but nonetheless it is. Even those that talk about transplantation donation, still very high. Over 90% are positive about donation in Indiana, because that's where I get my data from. Because that 90% is getting less and less that are going from strongly to now just to supporting. So that is a trend that you can't just ignore. We're seeing that continue to decline, and that is, this is right. fresh data, right? 24 to 25, important, right? Because this is the future. So we know there were 17,000 deceased donors in 2024. Approximately 7,300 of them were DCD donors, and we'll explain that, death by circulatory donation by circulatory death, which was a huge increase from 2023 to 2024, 20%, 24%. 10,000 were brain dead. So the majority are brain dead, but as you see that continue, we'll continue, that continues, the percentage continues to drift. So looking at it a different way, the dark blue are brain dead donors, slow increase over the years, but notice a significant decrease that's occurring in brain death donors. Don't completely understand that. We suspect some of that is improved treatment of drug overdoses, less drug deaths, decreased brain death patients. Some people believe it's because we do DCDs before brain death. I don't think that's a big portion of it. There are a few, but that's not a big portion. It really is, we're seeing a decline in brain death donors. And we're seeing an increase, significant increase in the red of DCD donors. So let's spend some time talking about donation after circulatory death, because it's a process. As an internist, you're likely to be involved in. Either you're a patient, or you'll be the declaring physician, or you're the ICU physician, or the trauma surgeon, or whomever's taking care of that patient before they become a donor hero. It turns out when your patient's in the ICU on a ventilator with appropriate GCS scores, coma scores, we're notified. All appeals are notified. Whether they think you're going to go downward or upward, most of those people, fortunate, leave the ICU and go home. But we begin to follow them. We know where they're at. We look at their labs. We pay attention to them. So if they do not do well, we understand the patient before the moment that they make the decision to withdraw life-saving care. And then things happen, and if the patient gets worse, and there's triggers for that. The patient's family may say, can I speak to somebody about donation? That's a trigger. The physician can begin the discussion about donation. We like to keep that a little minimal, and we'll talk about that. Or the physician and the family have already agreed they're going to withdraw life-saving care. So the procurement organization should not and is not involved in the care of any patient until the family and the treating physician team has said, we're going to withdraw life-saving care. And I want you to think about that, because at that moment, the worst moment of that person's life, not the patient two, the patient's family, right? And now we walk in with social workers and our teammates to sit down with the family and talk about the process of donation. That's probably the hardest job I've ever heard of in my life. Not sure I could do that, but I've got great people that do that. And at that time, when all those emotions are flying, is when the OPO makes a public appearance, if you will, right? It gets seen by the family. Some people have signed to donate, but didn't discuss this with their family. And now the family is being told, well, they signed their donation card. Frankly, legally, you can't revoke that in the United States today, right? So it can build up emotions at the bedside with the nurses, can build up emotions with the family. All those things are incredibly important. So very tough time. But once you get there, we discuss with the family, we look at whether they're signed up. If they're not, and the family says, no, that's fine. The patient gets the regular care that they would get, extubation and withdrawal life-saving care is designed by the care team. If they say yes, or the previous registered, we move forward with the process. And what you need to know just quickly, there's a lot that goes on in that process. I need serology and labs. I can't do anything without knowing those things, because the transplant center's not going to take organs from me, not going to transplant organs that they don't understand the virology behind it, the serology behind it, the whole stack of serology we test. And then and you have to know the blood type, of course. And then we can begin the process of allocation. Now, most of us probably think allocation, that's simple, right? There's a list, there's a kidney goes to the list. It's not that simple because every kidney has a risk factor to it, something we call a KDPI. Every center has their standards of what they want to get. And so there's computer programs that go through this, but it takes hours to allocate the organs. On top of that, if you're talking about the heart and the lung particularly, it's very difficult. It takes time for my team to get the lungs to a point that we can transplant. So they don't just take transplant. The lungs have to be working very well at the time of donation. So though my team will spend hours, sometimes a day, to make the lungs better. To assess the heart, we need an echo that shows the heart is working. In many patients, we need a cardiac cath. So this is after the family has already decided to withdraw life-saving care. And the point is, that's why we ask for labs. That's why we ask for bronchoscopies. That's why we ask for procedures. Because if we don't do those things, we can't take that sacred gift that this family is giving us, this patient's giving us, and put it safely in a recipient. So these are the things that cause this struggle at the bedside, right? The nurse has been working with this patient, they're dying, and now we say we want a cardiac cath, we want a bronchoscopy, we want to do this with the ventilator, we want to do those things, and we want you to draw bloods and place an art line. And they don't have that understanding of how that is so important. Without those things, we won't be able to donate particularly hearts and lungs, but even livers become harder and kidneys become harder. So that's the process I want you to be aware of. After we do those things, if we're just then staying with the DCD case and we're withdrawing life-saving care, we then take the patient, and generally with the family, we do what's called an honor walk, and I got a picture of that. And we go to usually the OR, sometimes the PACU, occasionally the ICU for extubation. So the family, usually 2 or 3 members, will go with the patient if they desire. They'll go to the OR with the medicine service or with the intensivist, whoever the declaring physician is, the medicine team. The patient will be extubated, and usual comfort care will be given to the patient. Nothing unusual. What you need to know about this withdrawal, and we'll talk about it probably a little bit more, is that's driven by the physician in the room. It's not driven by procurement, not driven by my transplant surgeon. My recovery surgeons aren't even in the OR. The OPO team is not in the OR at that time. There may be a couple of people, the social worker and people setting up things that need to be ready to go. But we are not involved in the withdrawal of life-saving care. That makes sense. It's ethically, morally correct. If after extubation, the patient dies in a given time, which is already there by standards, usually 2 hours, some places 90 minutes, then we progress to transplantation. There's a time that declaring death, the declaring physician just calls death. We wait 2 to 5 minutes, and then we begin the process. Family comes out of the OR, patient gets ready for recovery. It's very quick, very active. I wouldn't want to be the recovery surgeon. I'm glad that we have recovery surgeons, right? It's a very stressful couple minutes because you've got to move as quickly as possible because that's warm ischemic time. It's damage to the organs, and families going out, patients going in, things are moving quickly. Then we're able to get transplantation and move forward. But that's the process. Some of us understand, most of us don't. But that's just so little of what a procurement agency does, and we'll go through more. In the United States, most of what we're talking about in DCDs are planned withdrawals of life-saving care. The patient that's in the ICU is not likely to or not predicted to recover per their physician. Family members have said, we're done. We want to go ahead and withdraw life-saving care, and we want to make him as peaceful or her as peaceful as possible. And that's the process we sustain. In other parts of the world, they'll actually take people that have had sudden death, unwitnessed arrests, and they have ways to do those kind of things. We do not. We, on occasion, have seen patients with brain dead have a sudden cardiac arrest, they'll rush to the OR, but that's very rare as well. In the United States, when we talk about DCD, we're talking about controlled DCD. So this is Indiana, and this is just to show you what is occurring. As we talked about, and these are year to date, so these aren't full years. This was, I believe, the end of August or end of September. Take that back. This is where we are. So we have donations about the same as it was last year. You'll notice that we had a significant rise from 19 to 25, and that's because we improved the way we did things. We wanted to be one of the best OPOs. We improved DCDs. We did things that we'll talk about called normothermic regional perfusion. But you can see, as we discussed, brain deaths look like they're starting to go down on us. And DCDs continue to have rise. So we're able to keep the same transplant, but you've got to have DCD donation. In Indiana, over half of our donations wouldn't have occurred unless we did DCD. And when you think about organs transplanted, there is a difference between brain death and DCD. So brain dead donor, they're going to take the OR heart beating on the ventilator and go to the OR looking like a normal patient. The DCD, we wait till the heart stops. Heart stops, you're no longer perfusing organs. There's potential damage to organs. So you can see this is what it looks like, at least in Indiana this year. We're pretty good at getting more than 2-3 organs from each patient, which is important because the more organs we can procure from a patient, the better the gift for our society and, frankly, to the family. They understand that more good has been done in this awful situation. Brain death, you can see, and I show this, this is brain death over here versus DCDs over here. And the thing to note is it's just easier to get or to procure more gifts per donor with a brain dead patient, particularly when we look at things like lung and heart and deep. But I do want to know we're able to make significant improvement in the last couple of years of getting more livers per donor. This year, really working hard so we can get more lungs per donor, even in the DCD world. And even hearts are increasing. I believe this, and this are driven by what we call NRP, the regional perfusion that we do. Because now my surgeons can have time to recover the organ. They have time to now look at the organ, monitor the organ, and tell the receiving transplant team, this is a good liver. It looks good, it's functioning, and we've had 45 minutes on perfusion. Let's rock and roll, right? Otherwise, we just didn't get them in the past. So it's a big deal to be able to do some of these things that we'll talk about. And this, to me, is the most important slide. This is why we do what we do. Deaths on the wait list are decreasing. More and more patients are being listed every year. Sicker and sicker patients are being listed every year. We now do a lot of alcoholic cirrhosis, alcoholic hepatitis. When I was practicing, that was a no, hard stop. Now it's a growth. We're seeing sicker recipients every day. And despite that, we're seeing a significant decrease in death on the waiting list, which is this line here, and this is in the thousands, but it's declining, as you can see. Now, remember, 25, these are full years. This isn't, that's why the dotted line's there. I just estimated up to where it would look for full year. But deaths are decreasing on the waiting list. Now, we can be honest, if we start taking people off too sick to transplant, because we've been told by the government, we're watching your deaths on the waiting list of the transplant programs. So we then take people off waiting list. If you take somebody off the heart or lung waiting list or the liver waiting list, because they're too sick, they're going to die. So I added both together. Even adding both together, significant decreases. We're doing what we're supposed to do. So we may be not perfect, but I think as a system, we're better than we're given credit for, because we are doing what we're supposed to do. And we're doing what we want to accomplish, which is obviously improving people's lives and keeping them alive longer. So what an OPO does is so much more than what we discussed. And this is by regulation. It's not like we're picking and choosing the list. This is the whole, I'm not going to go through each slide, the words on here, but this is what we've talked about for the most part, identifying donors, getting them authorized, getting them to the recovery suite, and understanding who's got, how safe it is for transplant. Because very important that we procure the right organs for the right patients. Safety, quality is absolutely critical. Mistakes are not tolerable. Very important steps. This preserving and labeling and packaging is so much harder than it sounds. Because there's regulations for how many bags to be in, where the labels have to be. It's got to be in a hard box. The label's going to be on the outside of the box, the inside of the box. And that's important, right? Because you don't want to make mistakes. But you're in the OR, and you got 3 surgical teams all wanting to get the heck out of the OR. And you got to say, wait, and I'm talking to my transplant surgeon here now. Give these guys a break. Let them get their job done, right? Let them package, label appropriately, sign your paperwork on the way out the door. It's a stressful situation, but this is a lot of work just by itself. We run the match list. We have to keep perfect documentation. We got to keep blood and plasma for a long time. We report significant things to the government on every single case, and none of it is easily transportable from your electronic medical record to mine, so everything is typed in by my people. And pay attention. This all makes perfect sense. But there's more. We educate the population. We're told to educate the population. That donation rate that we talked about, signing your card, is monitored by the federal government. And if your state's declining, CMS can go to the OPO and say you're not doing your job. And they keep track of those things. And they keep track of the number of transplants compared to potential, or number of recoveries versus potential recoveries. So educating the populace is exceedingly important. Doing community relations. Every week we've got somewhere between 10 and 20 school programs going on. It's just a matter of going throughout because we cover the entire state for the most part, except for Lake County in Northwest Indiana. But that's part of it. So you've got to do that. You've got to then support the families. And you don't support the families just through donation. We don't walk away from the families at the end of donation. We support the families for as long as they want supported. The programs that we shoot for at least 2 years. That includes families who don't say yes. It includes families who say yes, but the patient didn't die in the 90 minutes to 120 minutes, so they didn't become donors. We support all of those families because they're all working with us through this terrible time. So there's a lot that goes on there. So you have to understand all of those things, document, pay attention to it, work with funeral homes, work with coroners, work with every hospital in the state of Indiana, in my case, or the state of Kentucky, in your case, and we have contracts and we work together. Donor council, all sorts of things. That's the process. It's a long, but the most important thing I think you should understand, to an OPO, the donor hero's family is critical, loved, and appreciated, and supported for as long as they need support. We had a 20-year heart donation from a donor hero. The recipient came, and the donor hero's family came just the other day to our program to meet for the first time. It's amazing things. But again, we're left in a public that doesn't understand donation. We're left in a social media world that feeds this disinformation. And frankly, sometimes from the government and from newspapers, we get those things. So we have to work on improving that. That's why marketing is important. That's why going to the schools is important. Sometimes we go to the schools because we want to get the students as they're beginning to get their driver's license, but we also want them to go home and talk to their families. And so they understand the process, right? And we have to drive those things to be positive. Lots of headwinds and lots of things we do that you may question, well, why is the OPO doing this? I mean, we have a great, actually, I've seen this. If this doesn't bring tears to your eyes, you don't have a heart. But it's a great documentary that's coming out. 4 different organ families, donor families, their story, or I guess 3 different organ families, their story. Incredible story to hear what the donor heroes and their families go through and how they appreciate the gift of donation years following. It's absolutely critical to understand. Obviously, we go to state fair, we go to ball games, we go to whatever it takes just to get out to talk to the public and help them understand. We educate our hospital systems, our nurses, our doctors as best we can. And this is this one's probably worth our couple minutes here. This is one of the
So I hear all the time
PSAs for
that
us.
the concern that doctors aren't going to try and save me because I've chosen to be an organ donor. I can tell you that is 100% absolutely false. My name is Deborah Rusk, and I'm an emergency medicine physician. I have been in practice for over 20 years in emergency departments here in Indianapolis. We're not going to limit things because you're an organ donor. In fact, usually in the emergency department, we don't know if you're an organ donor or not. It never discussion when we're taking care of you and when we're making clinical decisions about what we're going to do for you. So checking the box, being an organ donor, I think, yes, I would always tell people when they ask me, should I be? The answer is yes.
But that's a nice message for people my age. When you go to our younger donation, first of all, younger generation, they turned it off after 15 seconds. It's a TikTok world. So we also have TikTok things. I won't show you. I don't understand. No, that are just shoot for the younger generations. Because while it is not the donation process, it is getting us there. And that's why marketing is so important, because otherwise you get a message that nobody hears. So things we do, we work with our hospital partners. We send up donor hero walks as the patient's going to the OR, or if they're a brain dead patient as they're going to leave, when they go to our facility from another hospital, the family can go with them and understand that the hospital services hallway. It's absolutely a beautiful experience. It's great for the family. Obviously, if a family doesn't want this, we don't do that. We have that discussion so they know these are the things we do. There's a moment of silence before every recovery surgery. A moment of silence is just to remember the donor hero. We get some bits of information from the family. They help us write it. And it's just that one more moment. And we fly, if the families want, from the hospital's flags for donation, and we give the flags to the family. We give the family little teddy bears with the patient's heart sounds, blankets, all sorts of nice things, just to support them in their time of grief. We also have built, at least in our OPO, we have a memorial that we built for, it's a relatively new building. We commissioned a couple artists to build us a memorial. One did the walls, one did the tree. Beautiful tree. It's interactive. You put in your family member's name, and it will show pictures on the wall of that family member that the family's given us, the donor hero, and statements. And the lanterns, there's 82 lanterns for all the gifts that you can get from a single donor. And they change color with nice music. It's just really nice. And donor families appreciate it. They come out, they bring other family members, and they celebrate the gift of the donation that they had. Even years after, we're in the process of making sure everybody, because it started in 1980, so we don't have them all in yet, but that's our process. We want every donor hero to be able to be in the memorial. So you can come by and see that. We work with the families, right? This is all part of the process of the OPO. We have our aftercare service that provides grief counseling. We're there for fun. If you have questions about how the recipient's doing, we can't always give you the recipient's name, but we can reach out and see how they're doing. And if we have permission, we can tell you how they're doing. But we take care. Again, this is the key point. It's not just procuring organs. It's not just what, as a physician, we see in the ICU. It's supporting families forever. And I think that's critical. This is why, frankly, I joined the OPO. Because you can feel this when you walk in the building of a good OPO. This is the culture that you want. Things as a physician you should know. There's the Uniform Anatomical Gift Act, slightly different in every state, but basically all the same. And what that says, as a hospital, you have to work with the OPO to be able to help procure organs and promote donation. As a physician, you have to help preserve the organs prior to procurement. So, when I call, or I have my nurses call and talk to the doctor about changes in IV fluids, I need a bronchoscopy, whatever. It's because what our goal is is to continue to support the patient, give the patient the dignity they want, but make sure when they go for procurement, the organs are in the best shape possible. So the next recipient, the person that gets that gift, gets the best possible chance. And I don't have the slides here, but things matter. So the common thing, and we were talking, as a nephrologist, I rarely saw hypernatremia. In the procurement world, I always see hypernatremia because the brain doesn't work and you get diabetes insipidus. The sodium of the donor at the time, terminal sodium at the time of donation matters. If it's really high, the organ doesn't last as long. There's more graft dysfunctions, there's more graft loss. If it's within a reasonable normal range, best support we can give the patients. So when we call to talk about these things, it's really, really important, not even just today, 2, 3, 5 years down the road. It's surprising how much the physiology at time of donation matters. And that's why we work very hard to make it as normal as possible. And as a physician, we get frequently, I should be the one talking to the patient, the family about donation. I know the patient's family better than you. I've been taking care of the patient in the ICU for 2 weeks, whatever. The bottom line is, again, words matter. And we want to work with you. But we don't necessarily want you talking about donation because if you say the wrong thing, it makes things worse. How you say things matter. So if you're the good physician, the empathetic, compassionate physician I know you all are, you can work with the OPOs. They'll teach you bridging languages, how to speak, what words to use, and how to bring in the FA, the people that will support you at the time of the question about procurement and donation. But you've got to be very careful of what you say and how you say it because it impacts so much down the road. And sometimes it takes a lot of time. So I encourage you to think about if you want to be that physician, but I encourage you to work with your OPOs to learn the right way to approach it and make sure that we are aware. That's why we're in the ICU all the time, because we want to help you through these difficult times. So don't look at them as your enemies. They're your friends. We're here to work with you. Absolutely. But words matter. They just matter. Every word matters. So we talk to your patients when you are aware we're coming to. When the nurse calls us, you call us. There's triggers that we have for the patient on the ventilator. The patient's family says, I want to talk about donation. That's a trigger that brings us in. You begin the conversations about withdrawal of medical life care, or the physician has said, let me talk to you about donation. We've got to follow that as quickly as possible. Make sure that we're all on this. So if the physician brings the donation to the family, bring it. And then after, you have the discussion of withdrawal of life-saving care or brain death testing. We don't just walk in. We don't walk in to talk about donation, a gift, until you've made that decision. That decision's got nothing to do with the organ procurement of the organization, nor should it. But after you make it, we're here to support you, and we're aware of the patients. We will work with you to manage DCD patients in most states, in most hospitals. We actually then take control of the brain dead patients in Indiana. As I'll show you, we take them down to our procurement organization. So we'll transport them if they're not in one of our transplant hospitals. And you will be the one that declares brain death as cases. So I've got some of that. So again, in the OR, the team taking care of the patient before they die is the medical team, or the transplant surgery team, or not transplant surgery, the trauma surgery team generally, right? Those are the people in the OR, the ICU nurse. And in my mind, because I don't do this, right? That would be wrong. In my mind, this is the care you would give if you just extubated in your ICU. So we're going to withdraw life-saving care. We're going to extubate the patient, and we're not going to reintubate the patient, and we're going to take care of them. We're going to support them, sedate them, whatever they need. That is the physician's decision that's caring for the patient, not the OPO. The transplant surgeon, recovery surgeons aren't in the room. The OPO, for the most part, isn't in the room except for people to support the family. The declaring physician decides when the patient's dead, and we'll go over that. And then there's a hands-off period where we watch the patient, we don't do anything, and we make sure there isn't a recoverable circulatory beat. There's respiratory therapists, of course, to help with the extubation and all the other things. If you are a declaring physician, some of you may be, you have to make sure the patient has died. That's absolutely critical, right? And generally, it's an arterial pulsation. There's other processes you can use, but almost all of our patients have an art line and it's functional and working before they go to the OR. I'll have the EKGs on, but more than the EKG, you also want to make sure there's no pulses, right? You could echo if you wanted, there's a, and you can measure by arterial Doppler, but that's generally how it's done. After that occurs, you wait and you make sure there's no recovery spontaneously. And if there is, the clocks, you keep going. This has to occur, again, within 2 hours in most places, 90 minutes in some. If that doesn't happen, then the patient is taken back to the ICU and usual care is given to the patient. We as an OPO will continue to follow the patient's family and will continue to support the patient's family, but recovery will not occur. Any questions about that? Because that's really, really important, particularly internal medicine doctors. Things we'll talk about quickly because you're going to hear about them is allocation out of sequence, non-use, NRP or normothermic regional perfusion. And I'm going to just show you pictures. You guys don't need to worry about what these devices look like, what they are, but it's important to see them because they're changing our ability to improve donation in deceased donors. So I got it. That's coming up later. So this is normothermic regional perfusion. I forgot where I was. This is abdominal normothermic regional perfusion. What happens is the patient dies, as we've discussed. Surgeon rapidly goes in, places cannons, and there's different ways to approach it. Doesn't matter, but let's call it the vena cava in the aorta for now. They clamp up above the liver. So there's no perfusion that goes up to the heart or lungs, no perfusion to the brain. And they close off the legs because they're not being perfused well. And you're just literally with almost an ECMO machine. This makes it look too simple, but it's a really advanced machine, ECMO machine that perfuses the abdominal organs at normal temperature, normal oxygenation, and allows us then to procure the organ, look at the liver, touch the liver, give it time to get better if it's not looking good. Transplant surgeons will tell you all the things we test make it really difficult to let me understand what a liver looks like. What my transplant surgeon says the liver looks like, feels like, it's probably the most important thing that's there. We'll watch lactate clearance, watch the labs, and we'll perfuse for 45 minutes to make sure the liver works. That has moved us from livers we would not have procured in the past, not have been able to recover in the past, to livers that we're recovering now. Significant improvement in our ability to get liver transplantation for your patients. People believe it also improves our ability to kidneys. I'm not convinced yet that the data's out there for that. Liver, I'm really comfortable with. Now, there's slight variations to this theme. You can do a thoracic regional perfusion where we include the heart and the lungs. You clamp off the arteries to the brain so the brain does not get significant flow, and you actually make the heart beat again. You continue to ventilate the lungs, and then you transplant. You recover the organs from there. And you start with thoracic organs, and then you move to the abdominal organs. But this has been a game changer. You're going to hear about it because A, it's a game changer, but B, as you might imagine, it's expensive. So eventually the government's going to have to figure out who gets it, who doesn't get it, or they're going to try to figure out. We basically do it in almost 3/4 of our DCDs because we're so much happier. And that's why you see those livers numbers increasing, our heart and lung numbers increasing. So to us, it's exceedingly important. And what it does, it just improves the odds of getting organs. And you can see particularly organs that either we didn't go for before, the elderly patient, or the older patients were able to get more. What I've learned, and you can tell me if I'm wrong, the liver doesn't age. Liver is amazing, right? So we're transplanting 70, 74, 75-year-old livers that we would never have done before. It's a very resilient organ. And we're just, so let's go back to this AOOS, organs, allocated organs out of sequence. What that means is instead of the kidney going or the liver going to the person on top of the list of the transplant program says yes, because remember, we put the organ out there, the transplant service then has an hour to decide if they want it or not. They have a whole bunch of filters, so each transplant program is slightly different from another. It's a whole different hour talk. But you can see the concern here is disparity. This is, are you guys just taking organs and giving them to rich white people? Right? Is there a disparity? Are we doing something that I think every one of us thinks is unethical? And the answer is we're not. These organs that are allocated out of sequence, for the most part, are the ones that are the sickest organs. The livers that's been turned down by so many, all the programs, so much time, right, after we recover. And we call the more aggressive ones. Say, God, do you have a give it to you as an open offer out of sequence? And that's the organs of the ones I see at Indiana. Those are the ones that go through the list numbers of times. The other place you fall out of sequence is the patient's next to you, and they're crashing rapidly. This is a patient that's not going to survive or be able to sustain, keep alive 24, 48 hours so we can procure these organs in the normal system, allocate the normal way, and we've got 2 hours to get the OR for lucky. And we got to get a recovery surgeon, we got to get the hospital OR, we got to get everybody in order. I don't have time to allocate. I frequently don't have time for serology ahead of time. So then I have to get centers that are willing to take these organs prior to all of that. And those will frequently go out of sequence as well. So the problem I think we've had as an OPO, we told the government we do organs allocation out of system, out of order to reduce non-use. The government says, okay, that's a fair statement. And they said that we'll allow that. But what they're saying is non-use has gone up as well. What that is in actuality, in most cases, and I can't speak for every OPO, is we are taking older and older and sicker patients. And sometimes we'll recover a kidney and hope that it gets better on perfusion. And we'll try to allocate it. And it's just too sick to be able to be transplanted in the next patient. And that will be non-use. So I think it's a multifactorial cause of non-use that we have to understand we don't. What we do see with this rising out of sequence is more organs per patient being transplanted. That's the goal. Increasing the transplant rate is what I think out of sequence does. And again, decreasing death on the waiting list. So out of sequence isn't a negative, although many of us believe it because we don't understand the system. It's an important part of what we do. It should be monitored. It should be limited. We discuss every out of sequence organ we give every month and make sure we follow the correct pathway. We adjust our pathways to make sure we try to do is in sequence as much as possible, but it occurs. But I think it occurs for the right reasons in the United States. So real quick, cold preservation. We can now pump cold preservation, meaning cold temperatures, right? Below normal. Livers, kidneys, hearts, we have machines. They're just different sizes. They all look pretty much the same. I put the kidney in here. I can watch it in my center till I get it allocated, 12 hours in general, or for some of them. You can take this box and transport it on a plane, car, whatever, to the transplant center, depending where you're going. And they get the organ being perfused the entire time. Gives them the ability to reschedule surgeries, to get timing correct, to make sure the kidney is functioning well. It's monitored closely the entire time. So we know that it's good. Same thing is true for liver. This improves our ability to allocate organs. Used to be we just allocated organs in Indiana. We now have a 250-mile radius that we send organs to for the most part, sometimes even further. And we're able to do those things because of things like cold perfusion. Now, the problem with that box is I've got to have my pilot or my driver or whomever that goes with the organ to the transplant center stay there till they get the organ out of the box, because the box is expensive, it's reusable, we need it back. It becomes time and expensive, you can't follow it. This is a cool thing. This one is organ perfusion, cold organ perfusion that's completely disposable, single use. So I can put a kidney in here, and we did the other day to a donor that, or recipient that was had no chance for transplantation because they were 90%, 99% sensitized. Kidney went from us to California. We didn't even have to worry about getting the box back, and the patient had a successful transplantation. So it allows us to ship organs to places that are comfortable with it and not worry about getting everything back. Just makes it safer, easier, and more efficient. We can do the same thing with lungs. Literally perfuse and ventilate a lung in cold storage. Fascinating. Fits on the plane, goes wherever it needs to go, increasing our ability to get lungs where they need to go. Normothermic is a different and somewhat fascinating, even more expensive way to go. But you can take a liver, perfuse this liver, and there's like 5 units of blood that go with it. So there's an expense that you got to consider there as well. You put the liver on this right after you recover it. And instead of the normothermic regional perfusion we talked about, now it's getting regional perfusion, just the liver, for as long as they need. And the centers can watch it, make sure the liver's improving. They can take a marginal liver and say, we'll take this one from you, but we're going to watch it before we transplant it. If it gets better, we'll use it, which is entirely appropriate. Now, it's relatively new. There's only a few transplant centers, how many, that use it. Obviously, any of these pumps that go to a transplant center, they have to understand how to use the pump as well. So you just don't throw a pump at somebody. They've got to be trained to understand it. So not everybody does these yet, but this is open and working. This is how it fits in an airplane. And the same things even for a heart, right? Amazing things. Some of these things will be very important to us. I'm told that they've kept livers for 2 days on the perfusion before they used it, which is unheard of in the transplant world prior, right? That long of ischemia time. But it allows us more flexibility and hopefully more recovery. This is what we do in Indiana. We do everything. So we have a 6-bed ICU. So if you're a brain dead patient, we will move you from your hospital to our ICU. And we'll take care of the patient. We do cardiac caths, we can do echoes, we can do bronchoscopy, we can do whatever care needs to be done so that we can get the patient recovered and transplanted. We do it all there. It's easy on the surgeons because we don't have to worry about hospital time. It's better for the hospitals because we move people out of the ICU appropriately. So that we're not waiting 2-3 days in the hospital as we get the patient ready for procurement. They're moved to us. It's better on the families because this is a quiet, peaceful location that we allow the families to come to and visit when they want. And we have a special suite for when they're there. We move the patient to our special suite so it's comfortable. We got kids, toys for the kids, whatever else needs to be done. But it sets up a healing process and allows patients, families to see them in a better situation. They appear more comfortable, certainly appear more peaceful than ICUs, which are loud and so much going on. We have our own ambulances to move them. And we did this because we weren't happy with the ambulance services we had, because they don't send the best fancy ambulance to take care of our deceased donors. We have our own. And no transplant talk is ever correct without airplanes. So we have airplanes. But the bottom line is it's about transplantation. It's about recovery. So you have to monitor those things. And this is what we use as a measure. It's called ODE, observed to expected transplantation. It comes from the government. 1.0 means you're transplanting as many organs as you should based on your donor pool. 1.32 means you're transplanting 32% more livers in this case, 22% more hearts. You can see the numbers, 2.5 times more intestines in our OPO. Right? And then you watch this from year to year, and this is what makes me proud. And again, this isn't me, this is the people that work with me, because I haven't been there that long. But year over year, we're 12.7% more likely to transplant organs compared to the rest of the country. So that's what drives us. So am I doing it? Hopefully just about right. Oh, just about right. Bottom line is organ procurement is critical to the country. It's frankly, I believe, a blessing to donor families and a gift that personally I would want my family to allow me to give, even when I'm not making that final decision. But it's got to be done right. It's got to be done with compassion and empathy. As a physician, you're critically important to making this process more smooth. If you're on the negative side of this and you're pushing back, the family sense that. The families knows when my poor IDN bedside person comes in and says, I need this, and the doctor says no. They can read the nurses, right? So it's important that we are a team. We understand that. And that's what I find I have learned is making hospitals better is making it, everybody understands we're doing the same thing for the same reasons. And I think understanding aftercare helps, especially with the bedside nurse. So assist when you can, and importantly, sign your donor card, talk to your family, make sure they understand, and be comfortable if you're an outing where you have to discuss it. And it's dark when I hit that. So we're all done. I'll take questions.
Thank you so much, Dr. Kraus. I have a couple questions. I know we're a little short on time, but very fascinated by the allocation out of sequence issue. You've got two issues. It seems the sickest organs that some people don't want, and then you've got the sickest patients. Seems like the second one would be solved by an AI program, where you have a list, you've got an allocation list that automatically jumps up the sicker patients when they're crashing and they're going to be dead in the next 3 hours, that they automatically, seems like you could do that with a computer program.
There are multiple programs that do many of those things. So things, and I didn't want to go through allocation because it would take all day. Kids move to the top. Kidney liver or kidney livers, kidney hearts move to the top. So kidney goes to somebody's getting a second organ faster than it does to somebody else. People who are very sensitized, so I can't get kidney, move to the top. So there's a number of things that do. The computer programs do that, and it all works behind the scene. But even with that, every center still have to pick up the phone, or the surgeon has to review it and say, no, not this kidney today, for whatever reason. And we move on. And every center has an hour to say no. Now, most of them are very quick. It's not like we're waiting an hour 16 times because you couldn't. But the bottom line is when you go through that with the program, and transplant center sets programs they want. So kidneys that are sick have a high, what we call KDPI. Some programs don't want high ones, so it's automatically filtered out, so I don't have to bother calling a program that doesn't want them.
Right, so it ends up being out of sequence, and
but eventually you get out of sequence because you just can't get there.
That's right. You're very kind not to mention surgeon not available. Which
I didn't hear that. Next question.
Exactly. So the other one is the sad case that you showed just very briefly. Very familiar with that Missouri case, gunshot wound to the head. I was just stymied at how the neurosurgeon has to come in after the median sternotomy and try to rescue that patient off the table. That isn't ultimate in communication. I, as the physician, would want to know if my patient was being taken, even if the family. So if something happened, to make sure that going forward, that communication with the treating physician happens before anything else.
Well, and again, it's hard to know the real story there, because I did talk to the UofL on that one a little bit. But we were there for something else. There are a lot of things to lifting, right? Again, the physicians that decide to withdraw life-saving care, it's the physician taking care of that patient. The only thing that makes sense to me is that this was a team where there was an intensivist and a neurosurgeon, and they didn't talk, right?
Yep.
This, to me, I'll be quite honest, from my point as an OPL, I wouldn't have taken that patient to the OR. It was a gunshot head just to the top of the brain. Some of them was pretty simple. And it was like a very short time, 8-10 hours. I would want it more time. I would want to make sure that, but I do make the phone call, right? So I'm following patients that are on the DCD list or withdrawal life-saving care. If they're getting better, because I'm following everything every day. They're getting better. I make a phone call to the physician and say, just want to be sure we're still on the same page. Mr. Smith is better. I can see his GCSs are improving. Is this still what you and the family want? Sometimes the answer is yes. We've taken 2 people recently off DCD because the family said, no, let's give them more time, which is entirely appropriate. That makes me happy, not sad, right? It's not about just getting organs, it's about taking care of these patients. And we review the brain death. That's the other we're going to talk. You have protocols. Your physician declares brain death. We review all of it.
Yeah.
You didn't dot an I across the T, we're calling you back and say,
Right.
Dr. Williams, you got to redo the brain death. Now, unfortunately, sometimes Dr. Williams says, go to hell. I already did it once, I'm not doing it again. That's not the response I want, right? You know, there are certain rules you have to follow. If you're cold, you don't do brain death tests. Got barbiturates for 72 hours before you even make that declaration. So we follow, if you're good, you follow the rules. Right? And that's important. Do it right. But certainly people on withdrawal life-saving therapy can improve because we're not 100% as physicians, as you know. But those are the questions we have and the discussions we have. And at any point in time, the family can say, no, we're not going to go through with this. And we're fine with that. Right.
Can a donor dictate who, like the recipient, for example, he will say no substance abuser or alcoholic? And can that happen?
No, the donor family can say, my cousin Steve needs a kidney. Can we direct donate to Steve? In which case that's out of sequence,
Right.
but we'll call Steve's doctor or his transplant center. If Steve's on the list, been worked up, is the right blood type and fits, we'll send the kidney to Steve. And the rest of the organs will go wherever they go. So you can do directed donation, which frankly, I didn't know as a physician, was the home doctor, one of my home dialysis patients who got transplanted tells this story about meeting his donor because it was a relative, right? And it wasn't his time on the list, but it was a directed donation. I thought he was crazy, but I didn't want to ever say that because he's a really nice guy. But he was right. But it's an out of sequence. So that's one of the altruistic out of sequences that I would allow, and I think is absolutely appropriate. So we do allow donor family. We don't allow, we ask. Do you have somebody that you would like to direct a donation to?
Jason, do you have anyone in the chat?
One, we have a question from Dr. Lori Earnshaw. She's a former faculty here now, and she's hospice, palliative care. Says at the end of the talk, I wonder what the speaker thinks about using the language of quote withdrawal of life-saving care unquote, and whether or not the description of quote withdrawal of artificial maintenance of bodily functions or something similar may lessen the emotional heaviness and perceived moral distress of families making the decision to proceed with organ procurement.
Very good. I mean, words matter. And it's gone from pulling the plug, right? Which is absolutely awful. And what we've gone to is withdrawal medical therapy, which is what most people use today. And we're moving to withdrawal life-saving care. We're withdrawing life-saving care, but we're still caring for the patient. And what we have to frequently remind doctors sometimes is just because you're withdrawing life-saving care doesn't mean you're withdrawing care. It's your responsibility to care for this patient. And I have that discussion sometimes with doctors. I'm too busy to take care of your patient because I have to take care of a living patient. That drives me up the wall, right? Because these are still living patients with gifts to give other people. But very good. We should constantly think about the withdrawal life-saving care is actually new this year. And I can be trained quickly. Yeah.
You run a good OPO, but it only takes a little bit to poison the water.
I don't run it. I work for one.
But for the Kentucky case or the St. Louis case, what's the sequelae for?
So they're all looked at. So I'm not saying good, bad. St. Louis, I know well, is excellent OPO. Right. So even an excellent OPO will get a story here or there if they find it, right? And I don't think that was an OPO issue, but I don't know the details completely. I think that was a hospital issue. And a communication and collaboration issue. But the government looks at those things. Kentucky's being looked at closely, obviously, because they were looked at for a number of things, at least it's in the public. But the government looks at those things and they have said they're going to close OPO. Right? We're now in tiers, the top tiers. The best one, middle tiers. The middle ones, the bottom tiers, the worst ones, 3 tiers. And they said they're gonna be certified ones in third tier or programs, which is different, right? Because we've lived in this kind of world with the SRD our lives. But when do you hear about them closing dialysis? It's very hard. It doesn't happen. They say they're moving forward, and the University of Miami was the first one. So there is the potential to decertify. Hopefully, then you can appeal if you want. University of Miami has decided not to. But hopefully we figure out how to fill it. Because somebody's got to take care of those patients. But there is a process. It's looked at. If this is dialysis, the governance on steroids. Really a lot. We answer to everybody.
Well, thank you so much, Dr. Kraus.
Thanks.
Appreciate it.